Hello learners, my name is Dr. Leah Kaler. I'm a licensed clinical psychologist and prescribing psychologist, and today we are here for the introduction to substance use disorders and trauma-informed care. For far too long in the field, we have siloed mental health treatment of substance use disorder treatment. We cannot ignore the complexity of addiction, stress, and trauma, as well as how it is interconnected. So the purpose of this course and our time here together is to integrate these concepts and help us recognize that co-occurring conditions are not the exception to the rule, but are in fact the expectation. This brief introductory orientation to substance use disorders and trauma-informed care is going to provide a framework for how we begin to recognize addiction, stress, and trauma. It will provide you with some thoughts around how you might work with individuals that experience substance disorders, mental health conditions, and related such as trauma and stress. We're going to really hone in on the idea of trauma-informed care. This language has been used more frequently in the field, but is it truly being applied? I want us to be able to translate this type of language into action, and to do so, I'm going to provide you with knowledge and skills to get you there. One of the first things that we need to do is we need to pay attention to the idea of addiction as disconnection. We know that disconnection as human beings is intolerable. We want to be around other people. We thrive in a society where human beings can connect. Addiction as disconnection causes people to withdraw from loved ones, often withdrawing from oneself, from things that used to bring them joy, things that they used to be interested in, who they used to be, who they want to be. And it's quite a struggle to realize how to restore this connection and help people move forward from the place of disconnection to a place of recovery. Some of the fundamental pieces that you need to know are definitions around substance use disorders. The American Society of Addiction Medicine recently updated their definition of addiction to say, addiction is a treatable, chronic, medical disease involving complex interactions among brain circuits, genetics, environment, and life experiences. People with addiction use substances or behaviors, become compulsive, and often continue despite harmful consequences. Prevention efforts and treatment approaches for addiction are generally as successful as those of other chronic diseases. ASAM added this last sentence that is bolded there in 2019 as part of their update, and this was significant in that it instills hope and that we emphasize the point that change and recovery is possible. People can and do recover from addiction. Recognizing these prevention efforts and these approaches can be very effective. There's research that shows that substance use disorder treatment can be as effective as other medical care for conditions such as, for example, diabetes. We also know that in our field we have medication-assisted treatment, also known as MAT, or for things such as opioid use disorder. And we can see that these treatment approaches have been very successful. So today we're going to elaborate on these fundamental principles to provide you with a framework of what this looks like as we begin to move forward. So another piece of this quote is that addiction in the modern world can be best understood as a compulsive lifestyle that people adopt as a desperate substitute when they are dislocated from the myriad intimate ties between people and groups, from the family to the spiritual community, that are essential for every person in every type of society. Even the most harmful substitute lifestyles serve an adaptive function. Here we begin to tap into the concept of if someone has experienced trauma as part of their history. As an example, they might have maladaptive coping skills, and this could serve a purpose for them. We might recognize that this isn't the healthiest approach, but they might be working with the skills that they have in that moment, doing the best that they can to adapt and function. So there's a lot going on in this slide. Don't worry, we're going to go over everything. So we know that substance use disorder and serious mental illness conditions are highly interconnected among adults in our society. So here you can see some basic statistics around mental illness and substance use disorders. You might hear terms in the field such as serious mental illness. The acronym for that is SMI. Or severe persistent mental illness. The acronym for that is SPMI, such as borderline personality disorder, bipolar disorders, significant depression. In conjunction with substance use, there is very much an overlap. Approximately 3.6 million people have experienced substance use disorders and mental illness at the same time. You will begin to notice that co-occurring disorders, again, is not the exception to the rule, but that is the expectation. And you can see on the graph there, the overlaying circles right there in the middle, that 3.6 million, those are the adults with substance use disorders and serious mental illness. So we would be remiss not to talk about co-occurring conditions because it is likely, despite where you are in your life, in your career, if you're working in the behavioral health workforce, you will come across and maybe even work with individuals who have been touched by substance use disorders, as well as mental health disorders. Perhaps family of loved ones who have struggled with both. So we need to be able to recognize these pieces and how they interconnect to inform our approach, to be able to offer treatment that's effective and provide practical application for individuals to help them grow and heal. We see the cycle of traumatic events, and that includes substance use disorders and increased risk for maladaptive behaviors and increased risk for mental health conditions. But the opposite is true too. An individual has a mental health condition are at increased risk of substance use disorders. Individuals with substance use disorders are notably at higher risk for lifetime prevalence of PTSD among clients who are seeking substance use disorder treatment, ranging anywhere from 36 to 50%. So not only are we at increased risk if we have a substance use disorder or mental health conditions, we are at even more elevated risk of developing post-traumatic stress disorder. The acronym for that is PTSD. There are a number of reasons for this. We may consider adaptive skills, systemic issues in our society such as oppression. We might be looking at homelessness. We might be looking at someone who is unable to sustain work. As a result, the adverse consequences of this means that they may go about various different ways of trying to support their addiction, trying to obtain money to eat, to obtain housing, whatever those components might be. And as a consequence, the individual is at a higher likelihood to be involved in a traumatic event. Trauma survivors report substance involvement during traumatic incidences, such as being sexually assaulted while under the influence or being in a car accident while being intoxicated. They may experience greater substance use overall and more severe and persistent PTSD symptoms compared to an individual who does not report substance use and traumatic events. This goes to highlight what we've been talking about, that individuals that are already engaging in risky behaviors are more likely to have traumatic events for a variety of reasons, and these can all be very unique to one and their specific situation. So clients with severe mental illness also meet the criteria for post-traumatic stress disorder at rates of 4 to 5 times greater compared to the general population. They also report substance use and have higher risk behaviors compared to our non-traumatized clients. In 2019, among adults ages 18 and older, 1.4% or 3.6 million people had both severe mental illness and substance use disorder. 2.4 million people received some type of treatment, such as mental health disorder services or substance use disorder treatment or co-occurring treatment. However, what I can say is that most often these individuals struggle to get into any type of particular treatment because many of our treatment modalities do not recognize co-occurring disorders, as an integrated, holistic approach to treatment. So, for example, you might have someone going to seek mental health services, their substance use disorder is present and it's active, and the mental health provider might say to that individual, I can't continue to treat you and your mental health condition until you get your substance use disorder under control. Then that person may try to go to substance use disorder treatment and their mental health symptoms are present and exacerbated, and that provider might say, well, because of your mental illness, we can't treat you until you have the ability to self-regulate and develop your coping skills or receive medication, and until then, we cannot offer you substance use disorder treatment. So it's very much a problem. And there are many barriers to treatment. People may be bouncing in and out of these separate silos in our society, how we offer levels of care and various different types of treatment. So what we really truly want is co-occurring treatment. This is the ideal place to be, but it is unfortunately not always as common as we'd like. People who suffer from PTSD are between 2 and 4 times more likely to also battle with addiction compared to peers who do not struggle. Finally, following a traumatic incident, there may be the brain is going to produce fewer endorphins, and endorphins are chemicals that kind of make us feel happy. People with PTSD may turn to alcohol or other mood-enhancing drugs, which increase endorphin levels. However, over time, they may become reliant on these drugs to relieve feelings of depression or anxiety or irritability. And this can be described as chasing the dragon. When you have this endorphin release, eventually there will be a withdrawal period that follows. And so sometimes people may not always be able to get back to their normal baseline of what that chemical balance once was. And what used to be normal now is no longer normal because of the alterations in the chemical experience within our body. And then we need to use substances in order to get back to what used to be our baseline. So that chemical withdrawal really influences that person's day-to-day functioning and their overall well-being. So one of the things that we absolutely have to talk about is the mind-body-brain connection. As we move forward throughout this course, we just need to recognize that the three of these are very much intertwined. And an alteration in any one of these three is really going to affect the other two. So when we think about integrated care, as an example, physical, behavioral health treatment that happens in our culture, how do we start to connect this? How do we start to have conversations to normalize these processes? And as we see here on this little graph, we've got the mind, that's got our thoughts, beliefs, and emotions. We've got the body, which if someone is being in good health and good well-being, taking good care of themselves, hopefully they're engaging in exercise, nutrition, sleep, and self-care. However, with the population that we may be working with, perhaps they're not able to engage in or have the capacity or the luxury to be able to engage in some of these various different activities. And then we can see how the mind and the body, and then as we move over to the brain, this is going to impact our overall health and well-being. So our physical health, our mental health, and our social well-being. So it is very truly all interconnected, and we're going to expand on this much further as we have our time here together. So let's talk about Dr. Bruce Perry's work around sequential engagement and processing. Ultimately, here we must recognize the importance of brain development in the hierarchical organization of the human brain. This will also help to influence how the mind, body, and brain are connected when we have a deeper understanding of the brain and how the brain develops. So ultimately, the brain can be divided into 4 interconnected areas. We have the brainstem right at the very bottom there in red if you're looking at the diagram. Then as we move up, we have the diencephalon. Moving up further, we've got the limbic system, and then all the way at the top, we've got the cortex. The structure and the function and the complexity increases from the lower ends of the brain, starting at the brainstem there, as we move up. So the brainstem is a it's not simple, but it is one of the more simple areas of the brain. And then as we move up to the cortex, that is absolutely our most complex part of the brain. So the cortex mediates the most unique human functions. It has speech and language and abstract thought and the capacity to reflect on the past and envision the future. So we're looking at the bottom part of the brain. That's the more reptilian part. Again, if we move down to the brainstem in red, the brainstem is going to regulate our temperature, our respiratory system, our cardiac system. And then as we move up, we can see that arousal, sleep, and appetite and movement. And now as we continue to move upwards, we can see that reward and memory and bonding and emotions are all starting to come online here. And finally, again, as we reach that upper layer of the cortex, we have creativity starting to come into play there. So the ability to think and the language that we use and values and time, this orientation is all an idea of hope. So the brain organizes from the bottom up, and this is sequential. And if something is interrupted at any portion of the development, the later stages cannot fully develop and fully occur. So as you can see, if there is a disruption, such as a trauma that occurs, there can be a depressive symptom or effects of depressive symptoms on the brain's development. This can, of course, create relational difficulties, and as a result, this may be a situation where one may withdraw from loved ones, that they're starting to abuse mood-altering chemicals, and maybe they're experiencing guilt and shame. So when individuals enter treatment, they're not always recognizing the ties to this, and they don't necessarily need to know the ties to this. This can be very complicated, but we as professionals and learners in the field must recognize how the brain develops from the bottom up, and we must also recognize the need to have sequential engagement in order to be effective in the work that we do. And so with that, we have to help them regulate, relate, and reason. Now, I'm going to give this an example, and I don't necessarily mean this to be pejorative in any way, but think about working with a child, not necessarily in a professional capacity, but if you've ever interacted with a child, you've tried to reason with them, that may be difficult, but it may be even more difficult with a child who is highly emotional and maybe they're irrational. Now, that reasoning usually doesn't work out very well. Again, not the same thing, but when we're working with individuals who have experienced a traumatic event or individuals who have a lived experience, including substance use disorders, we may first try to help them regulate. And if we can get an individual to a place where they can self-regulate, that they can have coping strategies needed to really attach to their heart rate and their breathing and to stay grounded, then we can start to move into phases of being able to relate, being able to reflect, and allowing them to move into a situation where they can reason. And this might look like acceptance. This might look like having a higher power. It may look like understanding actions and adverse consequences, thought patterns. So, with the reason, we must also consider one's inside world, their outside world, and because of the idea of somatic input or sensory input. Now, people are recognizing the mind, brain, and body connection. If they're having sensory input, this could create a situation where one's fight, flight, or freeze system kicks into play, and maybe they are looking to flee a situation that they may feel as though is a threat. But maybe that threat is actually just a sound. Perhaps it's just a smell. And we need to help this individual be able to determine what is real versus perceived threat. We'll talk a bit more about this model and how it incorporates into our world. But I want to say that as we understand that the brain develops sequentially from the bottom up, it also develops from the inside out. And so the basic functions of the brainstem to the complex interactions of the cortex, each brain area has the capacity to create memory and to change in response to an experience, and to store those changes in its neural networks. So that gives us additional hope that if we can help an individual to regulate, we can understand that change is possible and that neuroplasticity is able to change and people can reason differently and have a different experience. So this is Dan Siegel's hand model of the brain. He is very prevalent in our field. This is a wonderful model. I use this all the time in my work with folks. It's a fantastic simplified explanation of what's going on, so you could use it with child clients, but I use this all the time when explaining the brain to adults, and I think that it's just a fabulous explanation. So I'm going to give you a brief overview of the hand model, but if you'd like to hear the expert Dan Siegel himself explain it, I will also link to his video. So as we can see here, we've got the spinal cord is the very base of your wrist if we're looking at the bottom hand photo. And then as we move up, basically the bottom of your palm is the brainstem. Your thumb is going to be the limbic system that's housing the amygdala and the hippocampus, and then our fingers up at the top are going to be the cortex. So if we look at the limbic system, which is your thumb there in the middle, it has connections going down to the brainstem, the spinal cord, and then that's going to connect to your body. And then it also has connection going up to your fingers, which is the cortex. So the amygdala is going to be very, very important here. The amygdala is, you can think about it as the brain's smoke alarm, and it basically takes in information from all of our surroundings, all of our senses, and it is looking for anything that may be a threat to us. And when we come across something that could potentially be a threat, whether that is real or perceived, the amygdala is going to basically put off its smoke alarm system and allow the rest of the brain to know. And when it does that, then we end up moving into fight, flight, or freeze. And then you can see in that green box lots of other potential emotions like collapse, big emotions, anger, fear, anxiety, survival, etc. So the amygdala works with the hippocampus, and we don't have that written down here necessarily, but the hippocampus, you may have heard of this before. It is very famous for its role in memory. So the hippocampus and the amygdala work hand in hand. The hippocampus talks to the amygdala and lets it know, hey, this is something that we've experienced before and this is very dangerous. Set off the smoke alarm. Or maybe it lets the amygdala know, hey, it's okay. That isn't a sign of danger. Actually, it's just fireworks at the 4th of July. So the amygdala and the hippocampus are going to be very important in determining if we move into fight, flight, or freeze, or if we're able to stay cool and calm. Now, let's move up to this top photo, and we can see that when the fingers are folded over, from your knuckles there down to your fingertips, that's going to be the prefrontal cortex. This is the, in my opinion, most important part of our brain. This is our thinking brain. This is our rational brain. This is where we can have executive functioning and think through things and pros and cons and consequences. And you can see in this blue box lots of other different things that the prefrontal cortex is in charge of. And so what we want ourselves, our clients, we want everyone to be in a state where their fingers are nicely folded over and that their brain is fully functioning, fully online. They're able to reason and think through consequences. But sometimes whenever a situation happens where we are triggered, where we get upset, then we move down to this bottom photo where the prefrontal cortex, the fingers flip up, and we call this flipping your lid. When you flip your lid, you can't necessarily think straight, you may not be able to be rational, and so it's very difficult to be reasonable. And so what we need to do when someone has their lid flipped is that we really need to help bring the fingers back down, or basically thinking about bringing the prefrontal cortex back online. That's what we really want to do, and we're going to talk about that much more here in our time together in this course, is how we bring a person from a state of flipping their lid to a place where they can become more calm and rational. So if we think about flipping your lid, that is where the sympathetic nervous system is. You may or may not have heard about this before. So you've got an autonomic nervous system that's broken down into two branches. The first branch is the sympathetic nervous system. That's your fight, flight, freeze, collapse. And so when someone has flipped their lid, their prefrontal cortex or their thinking brain is not online, that is very much when the sympathetic nervous system has fully taken over and we are in survival mode. But whenever we have the prefrontal cortex folded down in our top hand model here, hopefully this person is more in a parasympathetic nervous system state, where you may have also heard of this as rest and digest or feed and breed, where they're in a state where they can engage with their environment, where their body is much more relaxed. So this is just a brief overview of Dan Siegel's hand model. Like I said, I am going to link to his YouTube video so you can really see the expert in action if you'd like to hear even more about this. So a trauma-informed approach to substance use disorder treatment is really truly our goal. We want to not only use the language, but really to apply it. We want to understand what it means to be trauma-informed, and as such, we will be talking about practical applications, interventions, and related evidence practices from a trauma-informed lens. The idea is not what is wrong with you, but what has happened to you. And maybe most importantly, what is right with you? What is going well for you? And taking an emotionally intelligence and strength-based approach when working with others. Again, this is just an introduction and a taste tester for what is to come in our work together. So we want to talk about the role of an addiction counselor to build a very strong therapeutic alliance. This is going to be our top priority. And this very much may take time. It may require patience. And a huge part of this therapeutic alliance is being non-judgmental, offering a safe space for people to come and to be vulnerable and to learn to develop trust, because maybe that is not something that they've ever had in their life. We want to instill hope that change and recovery is possible. We want to continue to use that person-first language and any other trending language in the substance use field. So, sometimes whenever we think about any type of anonymous group that gets together, oftentimes they introduce themselves by, "Hi, my name is so-and-so, and I'm an addict." Well, we want to be able to ask that person, well, what else about you? What else would you like me to know about you and who you are? And we want to not neglect that addiction is part of one's lived experience and their story. However, we do not want this substance use disorder to be their full identity and to be all-encompassing. We really want to move away from that. We do not want addiction to define who it is that the person is, because they are very multidimensional, and addiction is just one of the many pieces of their lived experience. So we do not want to make addiction their one and only sole identity. And lastly, but definitely not least, is creating a safe environment. So whenever we think about setting up our space and where we're going to be working with these folks, we want to stay consistent. We want to be a consistent point of reference for folks, and they know what to expect from us. They know that they can expect consistency, that we're not going to change our approach. There aren't going to be any surprises, because perhaps this has been a part of their life in the past that has really shooken them up, or maybe flipped their lid, now that you know what that means. So we need to create a safe, welcoming, and engaging environment where trust can be built, where we can be non-judgmental, and people can develop a sense of hope for things that really can change, and there is recovery and things that can be different. So for the survivor, someone with this lived experience of substance use disorder and mental health disorders or trauma, things that we need to be really mindful of and help accomplish these things along the way is to resolve the difference between real danger So in our time together, we are going to talk much, much more about distinguishing between real and perceived danger. And we need to distinguish between the two of these because for some folks, they can be very, very different. But for folks who have experienced trauma, perceived danger may feel extremely real for them in that moment. And we're going to help them develop regulation, relaxation, and grounding skills. We know that people need to be able to self-regulate first and foremost prior to being able to do the work. We cannot rationally work with someone who is unable to self-regulate. Again, thinking about someone who has flipped their lid, we need to be able to bring those fingers down and bring the thinking brain back online, again, as we think about the hand-brain model. So by doing this, we need to teach people how to self-regulate and to bring their prefrontal cortex back online. So how do we work to develop that trust and develop the skills to regulate first? And this will be the topic of future lectures together. We can demonstrate the ability to self-regulate, to allow that to be something that people feel autonomous with. And once they develop these skills, they can demonstrate that they have the ability to self-soothe and self-rescue. And it might be in a counseling session that they can put these skills into practice. And then we want to encourage them to transition this into their outside world and use it in their day-to-day life. And also, we need to make a commitment to addressing trauma. We have to recognize that this is not always going to be easy for the survivor. It's going to be potentially very uncomfortable, actually. It's going to be important that we recognize as providers in the field that we're going to be sitting with people through their trauma. So there's a very real sense of vicarious trauma, compassion fatigue, and secondary response trauma. So we as providers must have a strong network around us for supervision, consultation, and being able to address how these things may affect us so that we don't experience burnout and that we can continue to be our best helping selves for others. So a couple of tips for connection. The experience of abandonment and betrayal, we want to help recognize that that's not going to be what the counseling experience is like. And we want to let our folks know that we are going to be consistent. We want to give folks permission to be hopeful that recovery is possible. The idea around attachment, and we're going to have a whole lecture on that, can be very scary for folks. So we want to help people work through these attachment issues. We're going to offer a sense of attunement with oneself and with others, so understanding our worldview and the worldview of another. We want to look at repairing relationships, maybe starting with oneself, and then we're going to move out to others in that individual's life. And we want to make sure that we are helping people and guiding them through repairing relationships with themselves and with others and thinking about how we can do this. We want to help individuals become responsible for their relationships, and oftentimes folks have an internal locus of control, so we want to help them recognize this. Maybe we're also going to look at spirituality and religion and attachment to one's higher power. And this can be very much a struggle for individuals who have experienced substance use disorder and trauma. They may have a lot of resentment here, and it may look like we have to provide them with good, orderly direction and finding balance to help people meet these needs and to expand relationships with themselves and others. So some key principles here for trauma care approaches as we move forward is creating safety, staying trustworthy. We're going to be transparent. We might include confrontation paired with empathy. And we may have to have some challenging conversations in a vulnerable and trustworthy and respectful manner, but that can really go a long way. Perhaps we're going to offer peer support and collaboration and just offering people a sense of mutually beneficial work together and offering them empowerment. So some concepts like internal locus of control, becoming self-aware, the ability to self-regulate, that all comes with choice, and that responsibility can be a little unnerving for folks. So we need to help people move through these moments. And we need to be culturally competent. So understanding our values, our beliefs, our attitudes, and our bias, which may be implicit bias. So we're going to talk about this together, and we're going to recognize how this information informs our approach and our counseling orientation and our style of relating and working with others. So finally, I want to say that recovery is a restoration of connection. Earlier we talked about addiction as disconnection. So we want to offer connection to meaning, connection to life-changing and life-giving relationships. So I'm very, very excited to embark on this journey with you. And as we get started, please don't hesitate to reach out in the comments and let me know what you're thinking. I look forward to getting to know you, and I hope that you're as excited about this course and our work together as I am. And I'm really hoping that you take a lot of knowledge and skills away in order to be effective in working with this population in the behavioral health workforce. So I appreciate your time, and I look forward to more lectures together.